As we have done in previous chapters, we talked a little bit about the anatomy, and now we're going to start talking about dysfunction and disorders. So we're first going to talk about segmental and tract lesions in the spinal region. And of course, when we say lesions, we mean any thing that affects the area. So it can be an injury, it can be a tumor, any dysfunction or something that's causing a problem in that area. So I'll apologize in advance, since this is a winter course. You guys get to listen to me cough my way through some of the lectures because I spend a lot of time outside in the winter, and so even though I don't have a cold, my throat is always dry. And so when I'm recording the lectures, sometimes you get to hear me cough. So I will hopefully not do that. I have my big glass of water, but I will try not to cough. There's my apology in advance. So lesions in the spinal region can interfere with information being sent either segmentally or through a vertical tract. So segmental function affects the function of a single spinal cord segment. We talked a little bit in the last lecture about the segmental organization of the spinal cord. And so segmental lesions interfere with neural function only at the level of the lesion. So whatever the lesion is, if it's a segmental effect, it is only at the level of that lesion. Vertical tract function conveys ascending and descending information. So all of the information that we talked about with the somatosensory system and the autonomic nervous system, that is all affected with vertical tract lesions. So lesions interrupting vertical tracts result in a loss of function below the level of the lesion. So a typical spinal cord injury is a vertical tract lesion. Something like a nerve root impingement is more of a segmental lesion. So we'll differentiate between those two types of lesions. So one of the assignments coming up in a couple of modules is a case study module, and I'm going to have you do it in groups. And so you'll be given a case study with a patient and their symptoms and the objective findings, and it will help you to determine whether it's a lesion in a segmental lesion or a vertical lesion, if you kind of keep these things in mind. So I realize that you guys are not neurologists and that PTAs do not diagnose things, but I have found that doing case studies and trying to determine the area of the lesion based on symptoms is a really good way to draw all this information together. So we're going to do that in a couple modules down the road towards the end of the quarter, and hopefully this will help you bring all this information together. So segmental signs include abnormal or lost sensation in a dermatomal distribution and or a lower motor neuron signs in a myotomal distribution. So as you know, a dermatome is the cutaneous area that is innervated by a single nerve root, and a myotome is the muscles that are innervated by a single nerve root. So that makes sense. If you have a segmental lesion, it innervates an individual spinal segment, and so you're going to get a dermatomal or myotomal distribution. So in the book on page 311, there is a little diagram, and I know that in the PowerPoint the print is extremely small and it's very hard to read, but it talks about segmental signs versus vertical tract signs. So the dotted lines are neural pathways that have been interrupted and don't convey information, and the solid lines are the uninterrupted pathways. So you can see in the first figure, the one on the left, the lesion interrupts axons in the left C5 spinal nerve, and it produces a loss of sensation from the C5 dermatome and weakness of the biceps and the brachioradialis, which are partially innervated by the C5 spinal nerve. In the second picture on the right, it's a hemisection of the spinal cord at C5, producing conditions below the level of the lesion, so below the C5 level, paralysis on the left side, loss of discriminative touch and conscious proprioceptive information from the left side, and analgesia and loss of discriminative temperature sensation from the right side. In addition, segmental losses are the same as in lesion A. So that's sort of that dark line going down the arm. So you get those segmental effects, but you also have effects below the level of the lesion. With a segmental lesion, you only get effects in that dermatomal or myotomal distribution. So lesions interrupting vertical tracts result in loss of communication to and or from the spinal levels below the lesion. So ascending tract signs include problems with the regulation of blood pressure, sweating, bladder and bowel control. Those are all autonomic dysfunction, right? Descending tract signs include paralysis, spasticity, muscle hypertonia, and if the lateral corticospinal tract is interrupted, Babinski sign is present. So now we're interrupting those motor tracts. So they're descending tract signs. The ascending tract signs tend to affect autonomic, and the descending tract signs tend to affect motor. You will also get sensory losses with ascending tract signs. So all signs of damage to the vertical tracts occur below the level of the lesion. That is a good thing to remember when we start talking about spinal cord injuries. So how do we differentiate a spinal region issue from a peripheral region issue? So peripheral region lesions produce deficits in the distribution of a peripheral nerve. So we said that the spinal region, it's dermatomal and myotomal, and with the peripheral region, it is distribution of a peripheral nerve. Peripheral nerve lesions cause altered or lost sensation in a peripheral nerve distribution. And they decrease or loss of muscle power in a peripheral nerve distribution, and no vertical tract signs, meaning no signs below the level of the lesion. So that's differentiating between a dermatomal or myotomal distribution, a peripheral nerve distribution, or a vertical tract distribution. That is one of the ways to tell the difference between these different lesions. So spinal region segmental signs occur when nerve roots or spinal nerves are compromised. So you could have a herniated disc that is impinging on a nerve root. You could have a lot of other things that might affect spinal nerves. So the segmental signs include altered or lost sensation in a dermatome. So there we go, we've got that dermatomal distribution. Decrease or lost muscle power in a myotome. There we've got that myotomal distribution. Decrease or lost phasic stretch reflex. And we know that has to do with that reflex arc, and that is in the spinal region that is affected. So that's how we're telling a difference between that and a peripheral lesion. So spinal region vertical tract signs include altered or lost sensation below the level of the lesion, and altered or lost descending control of blood pressure, pelvic viscera, and thermoregulation. So we're going to get into spinal cord injuries, and you'll see that those are often signs of spinal cord injuries, which is a vertical tract lesion. Upper motor neuron signs. So you might have upper motor neuron signs from a vertical tract lesion, and those include decrease or loss of muscle power, spasticity, muscle hypertonia, and if the lateral corticospinal tract is involved, a positive Babinski sign and clonus. So if you have spasticity and hypertonia and Babinski and clonus, you know that it is not a peripheral region lesion. You know that it's a spinal region lesion. Okay? So in traumatic spinal cord injury, it's usually caused by motor vehicle accidents, sports injuries, falls, or penetrating wounds. So these are usually accidental, that you don't get a traumatic spinal cord injury except by trauma. That's the traumatic part. So usually motor vehicle accidents, sports injuries, and falls typically do not sever the spinal cord. The damage that occurs is due to crush, hemorrhage, edema, or infarction, which is a loss of blood flow to the area. Penetrating wounds by a knife or a bullet or anything sharp can directly sever neurons in the spinal cord. So lots of different traumatic things that can cause spinal cord injuries. A lot of the spinal cord people I've worked with in the last few years are motor vehicle issues or motorcycle. So, or falling off roofs. There's the falls section. So I've worked with a couple of people with spinal cord injuries that have fallen off a roof. And that was their profession. They were a roofer. So that's pretty much puts an end to that profession. So immediately after a traumatic injury to the spinal cord functions below the lesions are completely depressed or lost. And this period of time is called spinal shock. It's usually due to inflammation. The inflammation interrupts the descending tracts that supply tonic facilitation to spinal cord neurons. So immediately after a traumatic spinal cord injury, you don't know what is going to come back until that inflammation subsides. So during spinal shock, all of these reflexes are lost or impaired. Somatic reflexes including stretch reflexes, withdrawal reflexes, and crossed extension reflexes. Autonomic reflexes including smooth muscle tone and reflexive emptying of the bladder or bowels. So we kind of skipped over that section in chapter 13 about the control of bladder and bowel, the details of it, but we're going to talk a little bit about it. So normally people after a traumatic spinal cord injury, when they're in acute care in the hospital, they are being catheterized, and then later on they learn to self-cath and control their bladder and bowels. One spinal cord patient that I've worked with a lot in the last couple of years, he was saying he has a T5 complete, was hit by a bus, the original cause of his injury, and he said, a lot of people ask him, well, do you think you'll ever walk again? And he says he doesn't even care about walking because that's not even a possibility for him. But being able to manage his bladder and prevent urinary tract infections, that's a huge big deal for him. It's a huge quality of life issue, and a urinary tract infection can ultimately kill you if it goes septic. So being able to manage that was a big thing for him. So walking, not an issue, but bladder control and managing his bladder and bowel issues, that's a big thing for quality of life. Autonomic regulation of blood pressure is impaired during spinal shock, and so a lot of times they have hypotension. Even afterwards, when they've recovered from the spinal shock, they still might have some issues with autonomic regulation, and that's something that we often are working on. Control of sweating and piloerection, which is your hair standing on end, is lost. It's an autonomic function. Several weeks after the injury, most people experience some recovery of cord function because the inflammation is down. And that leads to a return of the reflex activity below the lesion. So they might not have voluntary control below the lesion, but their autonomic control comes back. In some people, spinal neurons can become excessively excitable that result in stretch reflex hyperreflexia. So hyperreflexia develops as neuroplasticity produces new synapses in the reflex pathway. So that's good. Your body's trying to recover as much as it can during the recovery from that spinal cord injury. So a lot of times in chronic spinal cord injuries, which is the period after recovery from spinal shock, when the neurological deficit is stable, that is called the chronic period, and the period can last for decades. So a lot of times the person right after their spinal cord injury, they're in inpatient rehab and they're getting a lot of therapy. Then they might not be in therapy for a while, and they come back later on. A lot of times we'll see people in outpatient, they come back with, especially people that are dependent on their arms for mobility, they come back with shoulder injuries or postural issues or hypotension, and we're going to be working on that. Or they get to the point where they want to progress more, and we're working on that. So that's a really fun thing to work with people on. So the other changes secondary to spinal cord injuries are loss of lower motor neurons because they're not being stimulated, and so you lose them. It's a use it or lose it proposition. Changes in mechanical properties of muscle fibers. So you get atrophy and fibrosis of muscle fibers, alteration of contractile properties towards tonic muscle characteristics. So you get a lot of people with a significant amount of muscle tone after in the chronic period of a spinal cord injury. And two abnormalities in the interneuron activity can occur in below the level of the lesion. So you can get an inhibitory interneuron response to type 1A afferent activity. So that correlates with the hyperreflexia. Transmission from cutaneous afferents to lower motor neurons is facilitated, and that occurs because of loss of descending inhibition. So it's not just the fact that you have that vertical tract dysfunction, you also have some abnormal interneuron activity with a spinal cord injury. So there is a pathology box in the book, and it's Pathology 13.2, and I'll tell it's on there's a 13.1 for cauda syndrome, and we'll come back to that. 13.2 for chronic spinal cord injury. And one thing to really note on this is consciousness, communication, and memory are normal for a spinal cord patient. So they're going to have sensory, autonomic, and motor dysfunction depending on the level of the lesion, and we will talk more about that in the next section. The spinal region is affected. There tends to be a 4-to-1 ratio of males to females. Young males tend to get in more traumatic accidents than females, even though there certainly are females that have spinal cord injuries. So usually the pathology is crush, severance, hemorrhage, edema, or infarction of the spinal cord, and the etiology is trauma. So in the next section, we're going to talk about the classification of spinal cord injuries and some other things specific to spinal cord injuries.